Team, welcome over. Thank you for joining us for a special presentation from Cooper Vision. Dr. Sclafani, I'm going to hand it to you to get started.
Oh, this is wonderful. Thank you, Jenna. Oh, wow. It's wonderful to be here tonight. We have been such proud sponsors of WooU and, of course, the Scleral Lens Education Society. It's wonderful that they've collaborated together because you're bringing the best of both worlds together. And I've been enjoying the series of lectures that they put together. So, Elise, you've done a wonderful job, and Stephanie, of course, have done a wonderful job. And Dr. Paisano, it was so nice to hear you. Another nice Italian doctor out there. I hope someday we'll get to chat in person. So tonight, I'm here on behalf of Cooper Vision, and I'm very proud to have my colleague with me, Dr. Vivian Shabiyama. And I know that we've been chatting a lot about our patients who have severe dry eye. And we're going to shift gears a little bit. We're going to talk about some of those patients that might be more common in your practice or more common in the 800 or so doctors who are out listening tonight. Because fortunately, not all of our patients have such severe disease. And we're here to help those patients who are just suffering from a little bit of dry eye as opposed to severe dry eye. I'm Dr. Louise Sclafani. I am the head of the specialty lens portfolio at Cooper Vision, formerly of Synergize, and formerly at the University of Chicago, where I dealt with a lot of patients who had some of this severe disease. I do still see patients in a private practice, and so I do listening, learning every day, and hoping to make sure that I'm kept up to date as well. But I'm really proud to have my colleague and friend with us tonight, Dr. Vivian Shibiyama. Dr. Vivian hails from California, but she went over to the other side of the country and went to optometry school at Pennsylvania College of Optometry, where she graduated cum laude. She then did a specialty contact lens fellowship at the Jules Stein Eye Institute, and they were fortunate to have her join on. And she has been in that capacity since 2011, seeing patients. She also started the collaboration with the Dry Eye Center and within the Jules Stein. And so, of course, her practice encompasses a lot of these patients who really need her expertise in fitting scleral lenses as well as other specialty lenses for that advanced dry eye disease, but also for those patients who have refractive needs as well. So what brings Cooper Vision here is that, as you are probably aware, Cooper Vision has become more than a soft lens contact lens company. Although the soft lens portfolio can fit over 99.9% of our patients who have refractive needs, in 2017, Cooper Vision decided to go endeavor into the specialty eye care venues, and they acquired Paragon, followed by Blanchard in 2018, and followed by in 2022, Synergize was acquired. And our portfolio has this diverse group of different types of therapeutic focuses. Of course, myopia management is extremely well represented by Paragon and their CRT product, as well as with MiSight. The Blanchard portfolio added an extensive list of products with the main focus on the irregular cornea. And then, of course, the acquisition of Synergize brought hybrids as well as Synergize VS. And all of our products are destined to take care of patients with special needs with their corneas, but also for refractive needs such as astigmatism and presbyopia. So this really did build on the heritage and the strength of Cooper Vision's portfolio, like Biofinity Toric and MyDay Toric. But the specialty eye care branch goes much beyond that and treats all of these. Of note is, of course, all of our scleral multifocal lenses are a great addition, not just because of treating their regular cornea, but also for treating presbyopia as well as dry eye. So we're really excited about that. And many of our designs can be also added to your portfolio. We're hoping that's the case as we dive into this. Here you could see this is our family of 12 lens designs, but really it's more than that. Our 12 lenses this is just the family, but the series and the designs reach out to much more. So we have over 24 different specialty lenses that we offer to our patients. And so with that, I'm going to turn this discussion over to Dr. Shibiyama, and she's going to talk specifically about scleral lenses for the treatment of dry eye. So take it over, Viv.
Thank you so much, Louise. Hi, everybody. Thank you for allowing me to share my experience on the topic of fitting scleral lenses in the setting of dry eye. This topic is very near and dear to my heart. I only see patients with specialty lenses for the most part, and about half of those are those who are wearing the lenses for dry eye. And so most of us know by now that scleral lenses can improve comfort and vision in dry eye patients. But this is actually proven in the CLEAR study in 2021. In the TFOS-DUCE 2 report, scleral lenses have been identified as step 3 management in ocular surface treatment, which means that these lenses are best for patients who have failed conventional treatments like just topical lubricants or prescription immunomodulators.
And the other nice thing is that they also, obviously just improve the quality of vision, but it also still gives that benefit of providing freedom from wearing glasses, right?
Yes, definitely. So now that scleral lenses are more accessible and they're easier to fit, like I want to shift the conversation to a population who may not be considered those with like really severe advanced disease. Now, this patient can be one that you encounter more frequently in a private practice, one with normal refractive error who's just looking for better vision and also better comfort. And these patients, this patient, they're a little bit more particular about their vision. They have high standards for comfort and quality of vision. So to set yourself up for success with this population, you definitely want to lay everything out for them. And you want to talk about everything, including the pitfalls. So my initial conversation with the patient, I go over everything. I have a very in-depth conversation with them about it, and I give them probably more information than they need. And the reason I do that is kind of a funny story. I had a patient who was a soft lens wearer, a patient of mine for years, and she actually went out and sought out a second opinion on lens wear, and that doctor referred her back to me for scleral lenses. And I was so embarrassed that I didn't like have this conversation with her myself. And so from that day forward, I just made sure that anyone who's like looking for more comfort or better vision, I always tell them about, all the options that are available. And I always include scleral lenses. So now I know that a lot of us are hesitant to bring up scleral lenses because they hear gas permeable lens, and a lot of patients almost have this like visceral reaction to like the thought of an RGP, right? They've been wearing their soft lenses, they're comfortable, they're nervous about how a hard lens is going to feel in their eye. So I tell every one of these patients, your soft lens is comfortable because it's large, not because it's soft. So imagine that lens with the fluid underneath, and that's the comfort that you can get with a scleral lens. And then with this, they're a lot more open to the idea of trying a scleral lens, and they let me like talk them into it and try it out. So that's been really helpful for me, that dialogue.
In this case, bigger is better, right?
Yes,
So
definitely.
that's a great conversation to have with them because again, they just think that, they may have had that experience with that smaller GP and they're like, well, if it's bigger, it's got to hurt more, right?
Yeah.
And it's
Yeah.
absolutely the opposite of that. That's great. And it doesn't feel like a toenail in the eye like I heard one of my interns say one time.
Yeah, and they get really alarmed by the diameter, but once tell them it's going to feel good, it's similar to a soft lens, they're a lot more receptive to it. Um, so can we go back for a second? Because I want
Oh,
to talk a
sorry.
little bit about what you want to present to them as well. Like, no, you're not only talking about like changing the diameter and switching to a different type of lens, but you also want to talk about the pitfalls of the scleral lens, right? So um, these patients, they might have a little bit of dry eye and they may also deposit on their soft lenses. So you definitely want to go over like lens fogging and non-wetting and talk to them about the potential complications that you may come across. So you want to set them up for success and tell them that it's really important to comply with their dry eye treatments. And we'll talk about a little bit about like the wettability and the lens materials a little later in this presentation. So contact lens discomfort that initiates this conversation usually appears around the same time that presbyopia is settling in. So you need to talk about near vision with these patients. The last thing you want is to have a 20/20 patient who's just so unhappy with you because suddenly they can't read. So you want to know everything about them. You want to know what their goals for vision correction are. You want to know what they do for a living. And you want to go over all the options. I also like to tell patients that I have a lot more control in scleral lens multifocals than I do in traditional RGPs or soft lenses, just because in like the one fit modality, we can actually decenter the optics, which can make a really big difference in their vision. I also talk about the fitting period, letting them know that, you know, they're not committed, they have time. For me, Cooper gives us 90 days, but I actually tell my patient, you have 30 days from the day you pick up this lens to decide if this is something you want to move forward with. And the reason why I do that is because I don't want to order like 5 lenses and be at the end of my fitting period and realize this is not the way to go. Once that patient walks out the door with their lens, they're going to know within a week, is it more comfortable? Can they handle it? Is it better? And then once they, you know, commit to that, then I move forward and, you know, fine tune the fit and I give them the 90 days.
Yeah, that's really important to know because it does take longer to fit them. And because of that, Cooper Vision has actually just recently changed its policy. And across the board for all sclerals, GPs, and hybrids, it's 120 days now. So that really gives us that ability to talk to our patients and, you know, calm them and get them adapted to it. So yeah. Next next slide. Okay,
Next,
there you
yeah.
go.
So let's talk about diameter selection a little bit. And every doctor is going to have their way or their preference of choosing diameters, but generally that lens should be about 3.5 to 5.5 millimeters greater than their HVID. Smaller diameter lenses are considered those that are under 15, and larger diameter lenses are greater than 15. For me, I like to fit lenses that are larger, only because a lot of my patients have really severe disease, and rarely do I fit anything under 16. Larger diameters are typically better for patients that have really severe ocular surface disease, like graft versus host or Sjogren's, because these patients need that coverage on their conjunctiva. Your highly steep ectatic patients that have, you know, just the cone that walks in before they do into a room, they need like larger landings in order to distribute that compression so they're not blanching on their conjunctiva. But you know, smaller diameters can also be really advantageous. They are great for smaller apertures. They're great for patients that have tarsorrhaphies. You may also want to consider them for that patient we were talking about earlier, that patient that just wants a little better vision, that's not ectatic, that's just a normal, you know, refractive error patient, because a smaller diameter can be less intimidating to start with, and you can always increase it if you need to during your warranty period. So another thing about smaller lenses is that they're typically a little easier to fit because the toricity of the sclera is less like toric by the limbus. So you don't have to get as fancy with your landings. They're easier to design. They also tend to center better, these lenses. So sometimes you can get like less midday fogging because the lenses are aligning more, more evenly. So that's something you want to keep in mind. Next. Now, One Fit and Synergize both offer a variety of diameters. My preference is I just start with 17, and then I go smaller or larger depending on how that lens looks on the eye. And the One Fit lens actually now comes in 18, which is fantastic because only the landing part of that lens is changing. So you can use your 17-0 fitting set to fit that lens, and I've had really great success with that lens. Next. So scleral lenses can improve visual clarity and comfort, but what about the ocular health? What about the hypoxia? In the past, we would look at oxygen permeability based on the lens thickness and material, and we know that scleral lenses, there's a substantial and intentional tear pool that we create, and this can potentially hinder the amount of oxygen that comes into the eye. In this study by Langis, he talks about the material decay over T, but he also incorporates tear lens reservoir thickness. So according to this chart, to minimize corneal swelling induced by hypoxia, your lens thickness cannot be any thicker than 250 microns, and the corneal clearance must be about 100. But I find in clinical practice that this can sometimes be really hard to achieve. One Fit and VS are both available in really high decay materials and are both relatively thin. One Fit is actually 250 microns, but I find that thinner lenses tend to settle a little bit more. So I like to start with like initial clearance of about 200 to 250, knowing that that lens is going to settle as the day goes on. The best total clearance, in my opinion, is one that gives a patient the best comfort and doesn't stain. We need that tear layer. So if we are touching the cornea in any way, we're completely defeating the purpose of wearing this lens or fitting this lens for the patient. So if hypoxia is a concern, I usually like to see patients for their follow-ups later on in the day. And if they still have high clearance at like 3 p.m., then I will definitely bring that bulb down. In my decade of fitting scleral lenses, I actually rarely see patients with hypoxia. The few cases that I have are really the ones that have really, really sick corneas, and it's usually not due to the fit of the lens. Next. So ironically, with all this talk about oxygen permeability, we know that high DK materials actually have higher wetting angles, which can cause some issues with wettability. A greasy surface is not only blurry, it's also really uncomfortable. And this is a patient that will tell you they remove their lenses multiple times a day to clean and reinsert. I've had a few patients drop out of scleral lens wear because they were so frustrated with having to remove their lens throughout the day. So this is a very important issue to address with your patient. These irregular surfaces are really obvious in patients with severe disease, but you definitely want to look for it in your more mild cases too. We have to treat the underlying condition. Lens wettability is influenced by a few things. It's influenced by the manufacturing, the quality of the tear film, the blink of the patient, the solutions, and also the material that you choose. So you have the next slide, please. So when we're choosing materials, there's certain things that we want to consider. So ideally, we want our lenses to have the highest oxygen transmission with the lowest wetting angle. But how do we achieve that? We really have to rely on our surface coatings. Plasma treatments, which have been around forever, are great. They make the lens more hydrophilic, and they also decrease bacterial adhesion. But this treatment is not usually permanent, it usually wears off after a few months. Hydropeg is great because you can apply it to the lens, which can significantly increase the wettability and reduce the deposits and proteins that stick to the lens. And I find this treatment to be really helpful in patients who have like lid issues like GPC or lid wiper epitheliopathy. It can also be retreated at home once it wears off, so that's really helpful for the patient to make that lens last a little longer.
So these are lots of great options for our patients to look at, different materials, different coatings, different thicknesses. Of course, you've gone over, some of the best fitting practices for fitting our patients who have the regular cornea but the dry eye. But how, let's talk about how you utilize it in practice and a little study that was conducted recently.
So the study that was presented at GSLS this year, done by Daddy Fidel, was looking at the success of converting soft lens wearers into scleral lens wearers. Next. The purpose of the study was to see if scleral lenses can improve comfort in symptomatic soft lens wearers. Next. So they enrolled 20 patients. It was a prospective design, and they enrolled symptomatic soft lens wearers who had a contact lens comfort score of greater than 12, which is not good. They were fit in one fit med lenses, cleaned their lenses with ClearCare, and after 1 month, they were asked to repeat this questionnaire, and they were asked to rate comfort, clarity, dryness, and handling. The results was that there was a significant improvement in vision and comfort in these patients, and after 1 month of wearing these lenses, with little reduction in the ease of lens handling. So the conclusion of the study was that almost half of these soft lens patients became scleral lens converts. This is not majority, but think of it like this. You presented your scleral lenses to 20 of your patients, and 9 of them converted. You just converted 9 of your patients into lifelong patients of yours. So I think this shows great success in actually converting the soft lens patient to the scleral lens. It's that we assume that scleral lenses can be hard to handle for patients, but I actually think soft lenses are more difficult. They're flimsier, you can't tell if they're inside out, they're hard to see, they drop on the floor. If a patient can handle a soft lens, they most definitely can probably handle a scleral lens as well. And recently I had a patient, an 89-year-old lady who I fit in a scleral lens. And she would come in with a bubble under her lens at almost every follow-up. And it was to the point where I just thought, I don't think she can wear this lens safely. And I almost took it away from her. I even notified her corneal specialist. But she was so determined. And one day she just figured it out. She figured out the right setup for her, like at her kitchen table with her tools, with her little device. And she came into my chair and she had 20/40 vision from 2400. And she was just like, you didn't think I could do it. Look at me now. And it was so great. I was so proud of her, and we hugged and we laughed, and it was just such a beautiful moment. And so the moral of that is that you never want to underestimate the will of your patients to see better and to have better comfort. If
I,
there's a will, go ahead, Liz. I'll
I
just say if there's a will, they just need a little bit of guidance, and they will succeed.
your perseverance is great. I mean, and I think they just need to have that suggestion to do something, and we should never assume that they can't. And I know you and I were chatting, and my patient was in his 70s, but 89, that's a nice one, yeah. And he would come in with a bubble too, and I was like literally wanting to take those lenses away from him, and he's like, no, I see so much better. And the interesting thing about it was on paper, and if you look at the charts, he's only like a line and a half better at the most, but it's the quality of vision. It's the quality, and it just made him feel so much better about his vision, and he eventually got to do that. I remember one time I had the opportunity of visiting a patient at home because she did have some motility issues, and so she didn't live far from me, so I did a follow up at her home. But and I got to look at her house, and she literally had one bathroom set up with all of her scleral lens supplies. Like this, it was like a shrine. And I felt weird because I was like, because she said, every time I come in this bathroom, I think about you, Dr. Scleral. Like, oh, okay, that's good. Thank you. But she had all the paper towels and she had all the tools, and she was dedicated to wearing them. So we really do make a difference when we do this. So thank you very much, Viv. And I guess, the study says, that we always think of putting scleral lenses into those patients who are those train wrecks or who have tried everything else. And sometimes they've tried everything else, like a soft lens, multifocal or toric lens, and they've failed not because of irregular corneas, but because of dry eye and the lens just not, or their eye just not able to support a soft lens. So let's not give up on those people. And we know that our population's maturing, and as they get older, they get drier, they get more presbyopic, and here's a great opportunity for us. So did you want to add anything else, Viv?
No, that is it.
Okay, thank you. Well, just to summarize, in the chat there are there's a link for you to see what our portfolio is. I know some of you are probably surprised to know that CooperVision does have scleral lenses and has two different scleral lenses, the One Fit family as well as the Synergize VS. So please scan here or get the link that we have in the chat. Remember that, this is we are dedicated to making sure you're successful. So there is a specialty lens account executive assigned to different areas. So you do have a specialist there. We do offer, of course, web training. We are putting together a webinar in the next few months that will kind of teach you how to use some of the tools that we have. And we have a lot of marketing practice management tools for you to kind of grow your practice. So we really hope you do that. We're dedicated to, being progressive, and we have different ways of fitting. It could be you chatting with a consultant, or it could be you designing that lens yourself using one of our tools that we have. One of the things that we did change recently in May, and that is we do have an extended warranty. So it goes from rather than 90 days, we're extended to 120 days for all of our products across the board. And it's risk-free fitting too. So it's unlimited free exchanges with no cancellation fees for all of our specialty products. And this is new for a lot of our products. So this is, gives you the opportunity to take that chance to with your patient, and for them to also explore new modalities. It's very flexible too. If your patient, say you decide to put them in a hybrid to begin with, and they don't work in a hybrid, you could move them across over to any of our scleral lenses, including ScanFit Pro as well. And then, all of our pricing is now inclusive. There are no add-on fees for most of our options, including quad specific, notching, toric haptics, and of course front toric. So we do hope that you look and for your patients. Think of that dry eye patient as a potential scleral lens patient, but more important, look at CooperVision as that company who could provide a lens for your from cradle to wherever they go after that. So, from all different ages, for all different refractive needs, and for the continuum of care for all of their situations. So with that, do you have any questions? We have MC Blanchard on well looking at some. I don't see any questions right now. If there are any questions, MC, did you see
questions
any?
in the chat? I don't know. I guess you were both very, very clear in your explanations. Thank you very much, doctors.
Thank you, and have a good evening, everyone. Enjoy your Labor Day weekend. Bye-bye.
Bye.